Well, thank you everybody for joining us for this qiCommunity lunchtime lightning webinar on the 25th of September 2018. We're joined by Ralph Oldham, and we're going to discuss the new guidelines for heart failure and their relevance to primary care. My name's Tony Lemke. I'm a general practitioner in Austinville in northern New South Wales. And by Ralph. Where are you, Ralph?
So I'm a GP. I work in Carlton and North Fitzroy.
Carlton and Fitzroy.
I've got two practices. I tried to retire and then someone recruited me.
And Sarah is joining us from qiCommunity Central. Good afternoon, Sarah.
Good afternoon, everyone, and welcome.
So for today's chat, if you have any questions for Ralph, if you type them in the chat panel on your screen, welcome everybody from all over Australia to our discussion today. Now, it's an important discussion, Ralph. Heart failure, it sounds like a terrible word when you tell your patients failure. Heart failure, is that a big problem in Australia for general practice?
Oh, look, absolutely. As you can see from the first slide, it's quite an issue in terms of cost to both the community as well as to the hospitals. But really, the mortality and morbidity associated with heart failure is actually dreadful. And you can see there that the survival rate for chronic heart failure, is about 52% at 5 years. So if you've got someone who's basically you think's got heart, half of them will be dead in 5 years. I mean, that's worse than most cancers.
Absolutely, it's certainly a common presentation to our practice, and patients with heart failure present commonly also. So a lot of patients who present on a lot of occasions. Ralph, things have changed. The heart failure has recently launched a new set of guidelines for the management of heart failure, and you're an important part of that guideline team. Can you tell us about that process?
Yeah, look, it was a great process. So the National Heart Foundation pulled together a panel of expert cardiologists in the area from all fields and all over Australia. They invited a GP, which was me. They had a nurse there as well as a consumer rep. And it was a great process. We reviewed the current guidelines. We worked out where we thought a literature review would be the most benefit. We then got a company to do that for us. We then pulled all that information together and we applied a grade sort of rating as to whether it was good, high quality evidence or not. And then we sat down together and we actually worked through and everything was done by consensus. And it was a fantastic process, and it was actually a privilege to be part of it, actually.
I'm glad you found it worthwhile, Ralph, and thank you for representing primary care and general practice. It sounds like you were somewhat outnumbered on the committee.
Oh, look, I was the only GP there, but they listened. They listened to what I said, and when we get on to the titration algorithm, that was one of the things that I had a lot of input into, because I didn't think what was there before really represented what we needed to be doing.
So, Ralph, the practices in the qiCommunity are committed to proactive and systematic care for their patients. That's the key interest, I'm sure, of those people joining our webinar today. So we're going to focus on those issues that are most relevant to the GPs, practice nurses and practice managers who are working in the space of chronic disease management. What systems do they need to improve to better manage their patients with heart failure? And certainly there's scope for improvement in the outcomes that we're achieving. Is that right?
Look, absolutely. If you look at, there was an audit done of people being discharged from New South Wales hospitals. And when you compare those people or what they were discharged to what they should be on, only about 59% were on AFA and ARB, and that should easily be up to 80%, I would have thought. Only 60% were on a beta blocker, a heart failure specific beta blocker. And both of those are key in terms of managing heart failure. And then we talked about the mineral, aldactone and the mineral corticoids. Only 19% were on them. So there's a huge gap of people leaving hospital. Now, a lot of these people will not see a cardiologist for ages. And so, if we can then take the lead and work on these, it actually can make a big difference for our patients.
Well, Ralph, we in qiCommunity love an evidence practice gap. It gives us targets to work towards, so thank you for that. First of all, though, we need to build our registers. We need to know who our patients are and what they've got. Can you tell us how we should define and then classify our patients with heart failure?
Okay, so with time we've been moving away from the systolic, diastolic, congestive heart failure into two groups. Heart failure reduced ejection fraction, so that would be the closest to the old systolic dysfunction. And so these are people who have an ejection fraction below 50%. Now, previously we actually said below 40, but the evidence is now showing that between 40 and 50 they behave the same. So we now say below 50, heart failure reduced ejection fraction, and then we have heart failure ejection fraction, and that's in people who have heart failure and ejection fraction above 50%, and that would be what we would call the old diastolic. And you'll now see, you know, the reduced ejection fraction and preserved ejection fraction coming into your software. So best practice has already got the reduced and preserved ejection fraction as part of that diagnosis. So, you know, like we had with diabetes, it's not diabetes, it's type 1, type 2, gestational. So we need to be getting the classification right. Treatment is so different between the two groups.
So we'll talk about the difference in management. So to start with, we should be classifying our patients. Heart failure, yes, with reduced ejection fraction, or heart failure with preserved ejection fraction. They, as part of the diagnosis then, they need to have, do the patients need to have symptoms, or is this a diagnosis we can just make on an X-ray or an echo?
Yeah, so again, just to reiterate, heart failure is a clinical diagnosis. So they have to have symptoms and signs of heart failure. Once you have that, you then try to work out what sort of heart failure, and we do an echo to determine that. And that's where you'll get your reduced or preserved ejection fraction. If, however, you know, you've got someone, you know, who you're not sure whether they have heart failure or not, but let's say some of the signs are there and you do an echo and it supports the diagnosis, you would then go down the heart failure pathway. But if you're really not sure, you don't have access to an echo, you can do BNP or pro-BNP. Now, it's not currently rebated in Australia, it costs around $80, but it's actually very effective at excluding or ruling in heart failure. So that's a really good thing to do, and that's why it's in our algorithm in terms of making the diagnosis. And then once you've got the diagnosis, we have two pathways. The reduced ejection fraction pathway, which is where all the evidence is about saving lives and reducing mortality. The preserved ejection fraction, where in fact there's no particular treatment that we can use that really alters that course apart from managing the risk factors. So most of the guidelines have been concentrated on the reduced ejection fraction, where we've got a lot of trials.
So a patient with the classical symptoms of dyspnea of exertion, orthopnea, peripheral edema, investigated initially, if available, with an echo, can rule in or rule out heart failure at that stage. So consider a BNP, which is also has specificity in, for heart failure. And having done the echo, then we can classify them as reduced ejection fraction or preserved ejection fraction and manage them accordingly. And then we can build our registers of patients. Okay, thanks for that, Ralph. So having built our registers and made our diagnosis, we might start with some of the, there's a number of different ways of managing, both pharmaceutically and non-pharmaceutically, non-pharmacological. Can we make any difference using all these strategies?
Sorry, I just missed that last question with the...
Does the management we do, pharmacological, non-pharmacological, make any difference to outcomes in heart failure?
Oh, stunning differences. So we know that, you know, for every intervention we do with reduced ejection fraction, we'll get a 20 to 30% relative risk reduction in mortality or, you know, or morbidity. So, you know, and each of these interventions are actually cumulative. So we actually talk about having people on all the evidence-based medicine at the highest dose them on. And we'll talk a little bit about stable heart failure, whatever that means, because there's quite a shift saying there's no such thing as stable heart failure because their mortality, even on best treatment, is still significant.
So we'll refer our listeners to the actual guidelines where there is an enormous amount of detail about the medications that we might use. But Ralph, in summary form, this is the management algorithm that the guideline group has recommended.
Yes, and this is where they actually listened a lot to what I had to say because I wanted to make this absolutely relevant to primary care. And you can see that they have two pathways, a congested pathway and then a euvolemic pathway. Now, the difference is really important because if you are significantly fluid overloaded and you start a beta blocker, you can actually make their symptoms worse. So if someone has presented to you quite overloaded, we offload the fluid first, we add in an ACE inhibitor and an MRA. Once they actually then become euvolemic, we will add in a beta blocker. Whereas the big difference on our algorithm compared to everyone else is that on the euvolemic pathway, you can start an ACE inhibitor and a beta blocker together. Or you can do one and then the other, but very close to each other. And then you will titrate them up and add in an MRA. And interestingly here, you'll say that there's good evidence that titrating up the beta blocker ahead of the ACE inhibitor is a better strategy.
So diuretics, Ralph, are over to the left. So they're to move someone from the congested side to the euvolemic side, or how does diuretics fit into that algorithm?
So the diuretics are pure relief. So that's all they do. They have no impact on long-term outcomes. So they're just there to offload the fluid. And then as we add in the other treatments and, they are improving, we should be then down titrating the diuretics if they're no longer needed because they are offered no advantage. And certainly when we're adding in an MRA, you can actually reduce the diuretic to, with something, the latex with something like aldactone because aldactone still offloads the fluid, but it's much gentler, but has about a 20% relative risk reduction in all-cause mortality.
20%. So that MRA is classically in general practice aldactone,
yes.
and really we should be in the same way that our patients with ischemic heart disease need to be on aspirin, our patients with heart failure need to be on spironolactone.
Yes, so we talk about the three big ones, which is an ACE or an ARB, a heart failure-specific beta blocker, and then a mineral corticoid, such as aldactone or a eplerenone. So they're the three we want every person on. We want to be titrated to the maximum dose that they can tolerate. We want to do it relatively quickly. As we talk later on with the nurse-led clinics, the speed at which they get to target dose actually saves lives and prevents hospital presentations.
So start them on those three medications. The beta blockers, you can go back to that one for minutes there. The beta blockers, once they're euvolemic, or initially if they are, and then up-titrate those over weeks, Ralph.
Yes. So we're talking about you could see them weekly or even 2 weekly and increase their beta blockers as tolerated. And it's interesting, people will tolerate a much lower blood pressure than what you think. So, I will often titrate people down to a systolic of 95. And if they're asymptomatic, I have no concern whatsoever because I know I'll actually stop them from dropping dead. However, if they're 95 and they're symptomatic and they're a bit dizzy, well, then, of course, I will always back off a bit. But I'm surprised at how many people feel better at that sort of level.
Okay, so we want to be getting the doses to the maximum that's tolerated. And by tolerated, you mean whether they're falling over or not?
Yes.
Or feeling
absolutely.
dizzy or not?
Yes,
And Ralph, is there any point in doing an echo again once you've got them on the maximum doses? What else can you do after that?
Again, this is something new in the algorithm. It actually says to repeat the echocardiogram in 3 to 6 months. Now, I think this is an important statement because if you treat people, you can see recovery in their ejection fraction. And so they may go from 35 to 45 to 50. Now, if they're above 40, then in fact, leave them on their medications that they're on. We don't need to go down further in the pathway. However, their ejection fraction still remains below 35. There are a whole lot of other interventions that can be done to improve their quality of life and reduce their mortality. Now, some of them are very specific to cardiologists, but one of the things that are really exciting and interesting, are the new neprilysin inhibitors that's just hit the market. And if you have an ejection fraction less than 40%, they will decrease mortality by another 15 to 20% relative risk reduction.
So we're getting in often that will be more a cardiologist, some of those newer agents.
So things like ivabradine, whether they need pacing or defibrillators, to me that's the realm of the cardiologist. Certainly in Melbourne, I've got access to cardiologists, so often my patients are sort of shared care between the two, me and the cardiologist. And let me say, there's good evidence around that. But if you're more isolated, things like swapping over to, the ARNI class or the neprilysin inhibitors, that's something that can be done in general practice and will be an incremental benefit for a lot of your patients.
Ralph, did the guidelines committee, some of our patients with heart failure with reduced ejection fraction, their ejection fraction improves over the years that we monitor them until it gets back up into the 55, 60 range. Do we attribute, pharmacologically, do we continue on the medications? Do we titrate them back? Is there any evidence around what we should do in those circumstances?
So again, there's some good evidence, and within the guidelines, you'll see a statement that unless the underlying reversible cause, i.e. pregnancy, thyrotoxicosis, in those particular ones you can, but for everybody else, you on their target doses of medications.
So the viral cardiomyopathy sort of patient, when they improve, I wonder if that's a reversible cause or not.
Good question.
Ask the cardiologist.
That's where I'd be going.
Yeah. Ralph, on the side there, we've got, we might move on to the next slide then, Sarah, but we're talking there about some of the other non-pharmacological management of heart failure. So there are some features there, telemonitoring and telephone support. What was interesting for you in the non-pharmacological management, Ralph?
Look, I think there were a couple of things. Certainly, it reiterated the important point that management of people with heart failure can be complex, and having a team around you that will involve nurses, exercise physiologists, OTs, the works, will actually benefit your patients. I mean, and we've seen this time and time again. We know it worked for diabetes prevention. We know it worked for diabetes, COPD. Heart failure is exactly the same. If you have people all contributing to the care of your patient, they will do well. And interestingly enough, there is good evidence that shared care with a cardiologist and a GP has really great outcomes. So we need to think of also getting a cardiologist, if possible, in the team. And the telemonitoring and the telephone support program was an added benefit. So, nowadays with Skype consults, heart failure specific cardiologists, I think it opens up a huge area of support. Now, the other thing that really excited me was the nurse titration clinics. You want to talk about that now?
Well, yes, please.
Yeah.
Tell us about that.
Yeah, so one of the recommendations that came out with strong evidence was nurse titration clinics. So if you, again, we often work in a multidisciplinary environment. We have nurses to support what we do. This actually shows that if you have someone who understands and knows about heart failure as a nurse, and they get involved in the early intervention and up titration of people with their medications to target doses. They do really well. And the main thing was that they saw patients more frequently, more often than what the cardiologists and the GPs did. And so they got people up to target doses in a much shorter time frame, which then led on to better outcomes and fewer presentations to hospital. So the key here is that we can use our nurses to support titration of our medication, and we can get them to do it much more rapidly.
So one of the lessons there, Ralph, is that when a patient is diagnosed with heart failure, we should be seeing them quite frequently in that first period, not the every 3-month bit, but more frequently to get their medication up.
Yes.
If possible.
So when we did a project with the Northern Hospital, they now have a system where any person who's been admitted to hospital with heart failure has to be seen within a 2-week window, and they prefer, between 7 and 10 days. And that can be either a cardiologist or a nurse or a GP, but they need it to be reviewed for up titration of their medication.
Righto. So our GPs listening will be up to trot about taking on that role. It seems like exactly in the space where general practice should be involved.
And absolutely, because the reduction in hospital presentation, and it was just phenomenal. So this is a great intervention that we can do.
Now, the last recommendation there, Ralph, was exercise for heart failure patients. Is there evidence that exercise is beneficial?
And look, I know we've had a chat about this already, Tony, and I agree with you that the whole thing around exercise should be made more prominent. Now, if you look at the guidelines, they do say that exercise certainly improves outcomes, improves quality of life, improves people who are quite frail. Now, there were a couple of studies that showed absolutely stunning benefits in a coordinated exercise program for patients with heart failure. And in fact, one of them got to a point where the number of needed to treat exercises for no exercise, with death as an outcome, was a number of 5 patients over 3.4 years. Now, that's a stunning outcome. And a lot of that was led by an exercise program that was developed in Italy, believe it or not, and they followed patients for 10 years. So, the fundamentals, time and time again, diabetes, heart disease, COPD, now heart failure. People active, increasing some of their core strength leads to sustained benefits and also sustained quality of life in our patients. And, this is, again, where we need to be taking the lead. And certainly some of the multidisciplinary programs, we have a few around Melbourne, they will look after them for, 8 weeks, 12 weeks, but then we need to follow up with something to make sure that they continue it for the rest of their life.
I look forward to the guideline where the intervention like exercise with such a higher efficacy comes first, before the esoteric heart valve surgery and little pumps they put in and the other limited use technology results. But that's great that you looked at that, Ralph, and that it was recommended for all patients with heart failure as a means of improving both mortality and quality of life. Ralph, what about the use of daily weighing and 6-day action plans, which is the focus of many of our care planning arrangements? Did your committee look at the advantages of that patient self-empowerment and patient self-management approaches?
So if you looked at around the multidisciplinary sort of interventions and read the detail, there is no doubt that early intervention in patients who are deteriorating, again, will save a lot of issues further down the track. And in fact, that was one of the things that we did with the Northern Hospital. We sent out a heart failure nurse to work with the practices about educating patients with early intervention using the National Heart Foundation patient sort of heart failure booklet. And within there, they weigh themselves. And if you get them to present, if they've had 2 days increasing weight, we tell them to take their diuretic, but also see a doctor. Once you've had to up-titrate the medicine, their risk for a hospitalisation or even death goes up incrementally. So it's an indicator that something's not going right. And so getting them in, working out what's wrong, doing the intervention will stop them going to hospital, but then looking at their medication to make sure that they are, in fact, up to date with all the medications at evidence-based doses.
And the mainstay of that symptomatic deterioration or weight gain is often going to be diuretics in those circumstances, yes, in the initial stages.
So diuretics to get them over the hump, but then it's about having a really good look. Are they on the right medications? Are they on target doses? Do they need a repeat echo? Have they gone back down again? Will they need some of those other smaller interventions that we don't do in general practice? Have they been going to their exercise program? Have they restarted drinking alcohol? There's a whole lot of things that we need to go through. And, certainly that's really important for us to take a lead on as GPs.
And Ralph, the guidelines do go into a number of the comorbidities, including ischemic heart disease and atrial fibrillation and thyrotoxicosis and diabetes associated with heart disease. And we won't dwell on those today. The link to the guidelines is available. But yep, the concept of stable heart failure, we've got a patient, we've been looking after them for years, they've got heart failure, it's stable, we don't need to worry about them. Is that a fair diagnosis to make?
So at the recent conference, this was something that was debated because people talk about stable heart failure, but in reality, these people will still die. And one of you can see from the slide there that in people with, class 1 or 2, so these aren't too bad, a third will die over 3 years. Now, in the Paradigm study, which was a study that was specifically looking at the new neprilysin inhibitors, these were patients who were treated incredibly well. Now, to get onto it, they had to tolerate maximal doses of ACE inhibitors and maximum doses of the neprilysin inhibitors. So they'd already pushed out people who maybe were a little bit more severe. In that group, so these are highly selected, well grouped, so to speak. In that group, 20% died over 3 years. 20%, and these were the best treated. So heart failure is dreadful even on those who are treated completely well. And this is why, a 20% reduction in mortality, in this high-risk group actually means a lot. And so we need to be reviewing our heart failure patients, even if they're doing well, walking well, but they're not at target doses and they've got plenty of blood pressure to work around with, we should be up titrating. Absolutely.
And so, thank you, Ralph. That's a fantastic message. We can see thank you for your work on the guidelines. We can see that there is a gap between what the evidence tells us we should be doing and what we're achieving in practice with our patients in general practice. So this is a great topic for our qiCommunity practices. We appreciate the work you've done, both in initial and diabetes expert reference panel. Now you're an expert on heart failure. What's next, Ralph?
You really want to know? I mean, there is so many evidence-based gaps that I love to look at. So osteoporosis, the gap between, the number of people who have fractured hips and the number who ended up on anti-resorptive therapy is only about 10%. So huge amount of work to be done in osteoporosis.
All right.
So yeah, don't get me started. I've got lots of things I'd love to do.
A webinar for another time. So on behalf of all our participants in the qiCommunity, thanks, Ralph, for joining us today. We welcome your questions. Subsequently, there are some resources you can download. An evaluation screen will pop up when we close this meeting now. Sarah, we'll be meeting again in October. Do we know what the topic is?
I'm still finalising the topic, but I will be sending out a newsletter with all the links, so hopefully that will be out soon. Thank you so much.
Thank you, and this webinar will be available on the Improvement Foundation website for those who you want to refer to hear Ralph's words of wisdom later. Ralph.
Absolutely, yes. Thanks so much, Ralph. Thanks, Tony.